Hello, my name is Alan Appel, and I want to present to you a systematic review on the effect of vitamin D supplementation on the development or progression of osteoporosis. This is for the University of New England APN 760 in June of 2019. The objectives of this review are to take a look at the current research on vitamin D supplementation and its effect on potential and existing osteoporosis. We also want to determine if these findings can be applied in nutrition practice. Vitamin D is a fat-soluble vitamin. It's a steroid hormone. It's produced from cholesterol when your skin is exposed to the sun. It's also available in a few foods like fish, fortified cereal, and dairy. But without sufficient sunshine, supplements may be required because deficiency is common. It's enormous. 41.6% of the U.S. population is deficient, according to some estimates. Vitamin D receptors are found in over 30 organs in the body, and deficiency is associated with heart disease, cancer, immune system problems, bone health, and most importantly for this study, osteoporosis. The vitamin D metabolism operates with the sun exposure or some foods, and vitamin D is converted to calcidiol, which is hydroxy vitamin D, in the liver for storage. Calcidiol is converted to calcitriol, and in the kidneys, which is the steroid active form of the hormone. Calcitriol interacts with vitamin D receptors, which are found in almost all cells of the body, and turn genes on and off, changing the cells. It promotes absorption of calcium and phosphorus for bone health, mineralization, and strength. Now here's an interesting graphic of osteoporosis. The actual meaning of the word is porous bone, in which density and quality of bone in the body are reduced. You can see in this graphic a normal bone on the left, which is rather dense, and one that's osteoporotic on the right, which is not so dense. Porous bones become fragile, and they dramatically increase the risk of fracture. Bone loss occurs progressively and can be undetected, often with no symptoms, until there is a fracture. Bones build to peak bone mass in our 20s and 30s and then dissolve in resorption back into the blood, replaced by new bone, which is called formation, and the whole process is called remodeling. With osteoporosis, bone loss outpaces new bone formation, and this increases fracture risk, especially as you age. The prevalence of osteoporosis is significant. Worldwide, 1 in 3 women, 1 in 5 men 50 years and older risk osteoporotic fracture. Most common fractures of wrist, spine, and hip fracture is the most serious and may result in loss of independence and death, actually. I've known several people who have fallen, and then within 6 months they never recover. In 2004, the U.S. Surgeon General estimated that 10 million Americans over age 50 have osteoporosis, and this results in 1.5 million fractures annually, and estimated another 34 million are at risk of the disease. The annual cost is $18 billion a year, and that's in the U.S. alone, and it's a worldwide problem. How do you measure osteoporosis? The World Health Organization has a definition of bone mineral density with the femoral neck of 2.5 standard deviations or more below the young adult mean, which is what you develop in your 20s. If you look at the graphic, you can see right in the center there is the a view of the femoral neck, which is used to determine whether the bone density is viable or not. And if this gets reduced in size, you're vulnerable to hip fractures. Bone mineral density is measured using DEXA, which is a dual energy X-ray absorptiometry machine. If you have a t-score of -1 or above, this is normal bone density and is healthy. A t-score between -1 and -2.5 ends up to be a low bone mineral density score and is indicative of osteopenia. A t-score, again, of -2.5 or lower is osteoporosis. The serum 25-hydroxyvitamin D at various levels can be viewed as deficient, and some look at it as 20 nanograms per milliliter. Others say less than 30 nanograms per milliliter is indication of deficiency. There are other tests, the FRAX, which is an algorithm combining clinical risk factors and bone mineral density and number of fractures in a population, and there are other variables and indicators. But the two what we'll be looking for here mostly is bone mineral density and the serum hydroxyvitamin D in the blood. So the research question that the studies that we'll look at are focused on is, among adults, how does vitamin D supplementation affect the development or progression of osteoporosis as measured by DEXA or hydroxyvitamin D or bone fractures? So the selection strategy that's been employed to come up with the studies we've reviewed would be age of 18 plus, older than 18, 18 and older. Their other demographics are that they're human. We've eliminated and excluded animal studies. These are outpatient, free-living individuals. Health status can be any, so there could be osteoporosis or no osteoporosis. Some of the potential problems are, of course, osteoporosis or osteopenia. The study design preferences that we have are a random controlled trial, RCT, or a retrospective or cross-sectional study. The size of the groups in the study, the sample size has to be 10 or larger, and so does the control group. Study dropout rate was less than 20%. We're looking for, and the range of studies by age or the date is 2009 to 2019, which is the last decade. The authorship, we include the latest articles by the same authors and reject earlier articles. And if authors are different or primary research article is different, both articles will be included. Language is English. And of course, exclusion, we mentioned less than 18, animal studies, smaller group sizes, study dropout rate greater than 20%, and a year range of 2009, less than 2009. So our search strategy is using two major databases, PubMed and Embase. And in PubMed, we have the search terms are vitamin D, supplementation, osteoporosis, bone mineral density, and hydroxyvitamin D. And I've filtered this down to clinical trials. So we eliminated meta-studies, which were several, and they were very good, but we want to actually look at the original study data when the research was done. In Embase, we use the PICO option using osteoporosis, vitamin D, placebo, and bone density. And you can see the flow chart of the records that we started out with, which were 72 we pulled, and it boiled it down to there were no duplicates, and they were screened down, still 72, then went to full text articles down to 4. And I actually ended up with 4 articles, which is what we'll review here. I excluded 2 very good articles, but they were done by the industry, who had would have a built-in bias. It's quite possible of because they were selling the products, they were selling supplements, and would have a vested interest in recommending them. The studies, looking at the Shahriazi study, you have it's a small sample size, but it was a good study. It was the impact of vitamin D on supplementation. There were 206 males and 194 females. They ranged from 30 to 60 years old. There were subjects had vitamin D deficiency, and they received 50,000 vitamin D units. There were capsules, and the control group received, of course, a placebo. The outcome of the data was that there was a prevalence of osteoporosis via bone density status in the intervention group, and after the administration of vitamin D, that was significantly lowered from the control, which is in a percentage terms of bone mineral density, it was 32 versus 67%. So that's a significant difference. The treatment of vitamin D improves bone density was the conclusion. In the McDonald study, it was a good quality study as well. They took a look at the daily 1-year oral vitamin D3 at 400 international units or 1,000 international units, and compared that with a placebo. There were 305 healthy postmenopausal non-smoking women that were randomized into the three groups, the 400, the 1,000, and the placebo groups. The BMD loss at the hip was significantly less for the 1,000 international unit vitamin D group compared to the 400 or the placebo group. So it was here the increased amount of vitamin D that was supplemented had an effect where lower amounts of 400 did not. In the Demetriou study, there was this was an excellent study. It was taking a look at the records, the medical records from a clinic in which the supplements were administered, and they were 50,000 international units of vitamin D2, which is another version of vitamin D. And they found that there was a significant improvement in the bone mineral density, and in this case also the serum vitamin D. And there was certainly there was a drop in the vitamin D3, but there was an increase in the vitamin D2 and overall vitamin D2. So this program was appropriate and effective strategy to treat and prevent vitamin D deficiency. The only study that came in about actually less or neutral was the Hansen study. And it was an excellent study as well, an RCT study that compared a placebo to low and high dose supplements. You had 260 women who were 60 to 75, and they had insufficient levels of vitamin D in their system, 14 nanograms per milliliter, up to 27 nanograms per milliliter, which is a range of possibly deficiency and possibly not deficiency. What they found was they put in subject had a dose of 800. There was another IU. Another group had a dose of 50,000 IU, and it was for every 15 days, and a placebo. And they did this with capsules for a year. They found that the calcium absorption increased a bit, 1%, in the 50,000 IU group. And in the other groups, there was no significant change. There was a very slight increase in bone mineral density, total body mineral density, but it was very marginal at 1%. So they came to the conclusion that it really didn't matter whether you gave vitamin D or not in this case. So that was the results of this study. So it's never a clear picture in science on everything. The results of the PICO question were, among adults, how does vitamin D supplementation affect the development or progression of osteoporosis as measured by DEXA or hydroxyvitamin D or bone fracture? And the study population that we looked at were 3 RCTs and 1 retrospective study of adults aged 18 and older. The total number of participants in the study was a little over 1,000. The intervention was oral, a vitamin D supplement, and we saw one study with 50,000, another one with 400 and 1,000, another study with 800 international units per day, or 50,000, and the retrospective study of the clinic records was that 50,000 IU was given for 8 weeks, and then it was an alternate every 2 weeks after that. The outcome of all of this was among adults, most evidence shows vitamin D supplementation reduces development of progression of osteoporosis or the development of it. And 3 studies showed significant improvement, such as a T-score of 0.81 versus 0.30 for the control. And a 4th study showed very minor improvement. The overall conclusion and evidence grade here is that among adults, the preponderance of the evidence shows that vitamin D supplementation improves. That is, it reduces the progression of osteoporosis, measured by DEXA, hydroxyvitamin D in the blood, or bone fractures. The subjects with greater vitamin D deficiency, for example, if you had less than 20 nanograms per milliliter, they may experience significant improvement. Subjects with no vitamin D deficiency, for example, greater than 30 nanograms per milliliter, may experience no significant improvement. And the evidence grade on the overall of the studies was 2, and it was fair. So some of the strengths of the studies we looked at, 2 studies were RCT in support of the conclusion. I like this graphic here of grandma doing a handstand. And it does show the strength anyway. There were 2 RCT studies showed substantial bone health improvement. The statistical methodology in the RCTs appeared to be robust. I saw no problem there. And of course, the one non-RCT study, you can't use statistical methodology with that because it was looking at just the actual data and not a sample. One retrospective study of medical records showed very high vitamin D serum results. The study analyzed records of all patients supplemented instead of a sample. Studies reviewed showed no evidence of bias. The limitations, a limited number of studies are available in the last 10 years, which is a problem. It'd be nice to have larger and bigger ones. 2 studies were eliminated because they included calcium and vitamin D supplementation, so it would be difficult to know what the effects of the D were when you mix it with another nutrient. 2 studies in support of the conclusion of supplementation benefit were eliminated because they were funded by companies selling vitamin D supplements. And they may have been perfectly good studies, but they were eliminated for that possible bias. One RCT study did not find a difference between the effects of high dose, low dose, and placebo supplement intake that they felt was sufficient to recommend supplementation. And another limitation is the limited size of the studies. For example, the subjects in the different studies were 400, 305, 39, and 230. So the implications for research and practice. In research, as a standard in most studies, larger research studies are needed to verify the results of these studies. That's for sure. It would be nice to have several thousand in each study. The research should be done to determine the optimum level of vitamin D serum. It would be nice to know just about where people should be, and there's some controversy about that. The research should be done on the efficacy of combining vitamin D with other nutrients, such as calcium. Studies of multivitamins were excluded from this review, and that may be the best way to go is with a multivitamin, because you are getting around the reductionist approach of looking at only one vitamin. Research should be done to determine the vitamin D needs of various ethnic and age groups, young people in particular, because there are possible precursors to osteoporosis which may begin in youth. We don't know, and it would be good to know and perhaps prevent this sort of thing early on. In practice, supplemental vitamin D should be recommended in cases of deficiency, which may be defined as less than 20 nanograms per milliliter or less than 30 nanograms per milliliter. Vitamin D supplement compliance rates, sun exposure, diet, and individual risk factors such as age should be considered by nutritionists on an individual client basis when deciding whether to recommend supplementation. What follows are the references which you can look up and verify the data we've taken a look at here. I hope you enjoyed the presentation. Thank you. Goodbye.